Okay. So I want to thank everyone for attending today's webinar. It's titled The Elder Mistreatment Emergency Department Toolkit, Improving Elder Mistreatment, Identification, and Response. This webinar has been organized by NAPSA's Research to Practice Interest Group. I am Julie Morawski. I'm the Assistant Director of NAPSA, and I will be moderating today, and I'm very happy to welcome you to this webinar on behalf of NAPSA. For those of you who are not aware, NAPSA, or the National Adult Protective Services Association, is a nonprofit membership organization that exists to provide training, advocacy, and networking opportunities for APS workers, allied professionals, victims of abuse, and anyone interested in preventing and raising awareness of elder and adult abuse. Please visit our website, www.napsa-now.org, to learn more and join us. A little housekeeping tips for you. All listeners have been muted, but we do want to encourage you to ask questions in the chat box. There will be time at the end of the presentation for questions and answers, so ask away in the chat box. And today's presentation is being recorded. And the recording will be accessible on the NAPSA website. Again, it's napsa-now.org. You can go to that website, and under About NAPSA, there is a NAPSA Research to Practice Interest Group page. And on that page, you can find a link to the recording. Today, I'm very pleased to be announcing today's speakers. Kristen Lees-Haggerty, PhD, Project Director at Education Development Center, or EDC, is a project director whose work focuses on developing and scaling innovations to improve healthcare for older adults. Dr. Lees-Haggerty is project director for the National Collaboratory to Address Elder Mistreatment, where she coordinates a team of national elder mistreatment experts from across the country to design and test a care model for identifying and responding to elder mistreatment in emergency departments. Dr. Lees-Haggerty is PI on an award from the NA National Institute of Justice to investigate barriers and facilitators to communication between adult protective services and mandated reporters of elder mistreatment. Additionally, Dr. Lees-Haggerty works on the dissemination of the UCLA Alzheimer and Dementia Care Program, a successful comprehensive dementia care model that is being prepared for implementation in healthcare practices across the U.S. Welcome, Dr. Lees-Haggerty. And we are also joined today by Bree Cunningham, who is an APS director. Ms. Cunningham is the Adult Protective Services Director for the Massachusetts, sorry about that, Executive Office of Elder Affairs, and has been in this role since June of 2018. Ms. Cunningham started her career at Elder Affairs in 2011, where she was the regional manager for protective services, overseeing the Western Protective Services agencies. Prior to this, Ms. Cunningham was the director of special projects, as well as the deputy director of operations for the Massachusetts, I said it right that time, Sex Offender Registry Board. Welcome, Bree. Thank you, Kristen and Bree, for joining us today. We are thrilled to have you, and I'm going to turn it over to you.
Thank you so much, Julie. Thanks for the opportunity to be here. I wanted to, before we jump in, just reiterate Julie's request that people please do use the chat. And I'm actually wondering if we can see it. So if anybody on there could just chat in something, where you're from, your role, that would be great. Then we can just see if the chat is working and get it going. The chat is disabled. Okay. So it looks like, okay, there's a Q&A box and a chat box. So maybe it's the Q&A box we need to be looking at. Okay, yeah, so participants could please use the Q&A box. Great, now I'm seeing them come in there. Yeah, I'd love to keep seeing states that people are calling in from. This is great.
Hawaii, Louisiana, this is great, wow.
Awesome, thank you all for making the time. Okay, the next tech thing I'm gonna do is try to share my screen the right way, so please bear with me for just 1 second. And are you all seeing the slide? Just the slide. Awesome. Okay, so I think we're ready. I'm going to attempt to monitor some of the Q&A while I talk, but I think Julie will also be looking there. And we will have plenty of time for questions at the end of the presentation. So feel free to pop them in the Q&A, and then we'll come back to them if we don't get to them in real time. Okay, so I guess I'll just get started here. My name again is Kristen Lees-Haggerty. I am the project director for the National Collaboratory to Address Elder Mistreatment. We're here today presenting on a feasibility study that we conducted on the Elder Mistreatment Emergency Department Toolkit. I'm so excited that Bree Cunningham could join today. She had a lot to do with the design and implementation of the model, especially here in Massachusetts. So I'm calling in from Massachusetts. Education Development Center is an international nonprofit organization, but our headquarters are in Massachusetts, and that's where I'm calling in from today. So let me jump in. What we will be discussing today is I'm going to tell you a little bit about the National Collaboratory to Address Elder Mistreatment more broadly, and then I'll focus in on the Elder Mistreatment Emergency Department Toolkit and show you some results from a recent feasibility study that we conducted. And then we'll zoom in even further and talk about specifically what we learned from implementing this toolkit in Massachusetts. And Bree will speak to the role of Adult Protective Services and what they were able to do here in Massachusetts and what we all learned together from that experience. Then we'll have a bit of time for next steps and a Q&A. Okay, so the National Collaboratory to Address Elder Mistreatment. The National Collaboratory is a group of experts in elder mistreatment who've come together with support from the John A. Hartford Foundation, the Gordon and Betty Moore Foundation, and the Health Foundation for Western and Central New York, with the goal of working together to design and test a care model for improving elder mistreatment identification and response in hospital emergency departments. Education Development Center, or EDC, is the coordinating center of the collaboratory, and we work alongside our founding partners, which include Keck School of Medicine at USC, UMass Medical School, UT Health, and Weill Cornell Medical College. In addition to these founding partners, since we began our work together in 2016, we've worked really hard to build a network of partners, some of which are represented on this slide. And these include partners in a diverse set of clinical sites, as well as state and federal agencies and national initiatives like the Geriatric Emergency Department Collaborative, for example. We engaged with these partners to help us from the very beginning to design the model, to test its feasibility, and now in our current phase of work, we're working to disseminate the model across the country. Next, I'd like to tell you a little bit about our process for how we designed the model and how we got to the feasibility study. So we began this work with a planning phase where we conducted formative research. This helped us determine where and how to focus our work. So actually at the beginning, we didn't know that we were going to focus in the emergency department, and I'll say a little bit more about how we got there in just a minute. Our formative research included a literature review that was led by the Weill Cornell team, and that reviewed programs for addressing elder mistreatment with a focus on hospitals and the level of resources that were needed to implement those programs. We also held focus groups and interviews with clinical staff and leaders from a wide range of healthcare settings. And we held focus groups and interviews with Adult Protective Services and community-based organizations that had roles in addressing elder mistreatment. Based on that formative research, we decided that the best starting place, at least for our intervention, was hospital emergency departments. And so from the outset, we had the goal of designing a model that could be implemented in hospitals with a wide range of available resources. So not just the large academic health systems that have existing access to elder mistreatment expert researchers and clinicians, but all types of hospitals. In the next kind of phase of our work, we engaged in iterative design process where we developed a paper prototype of what the Elder Mistreatment Emergency Department Toolkit would look like. We again engaged our partners in focus groups and expert stakeholder review to help us modify that tool and build it. A lot of what we learned during this process was, from clinicians especially, was you need to make it leaner. You need to make it easier to implement. You need to have the training be shorter, the screening tool be shorter. So we worked very closely with people on the ground to try to make it as realistic as possible. And then finally, the piece I'm going to share the most about today is the feasibility study. And I'll say more about that later, but it was really a small mixed methods design where we engaged 5 hospital emergency departments across the US to implement the model for 9 months. And I'm just checking the chat. Oh, great. Okay, so now the chat and the Q&A are working. So we should be good. You have ways to reach us. Okay, so let me try to hide some stuff so I can see what I'm doing here and tell you more about why the emergency department. A couple of notes about why we decided to focus, at least to start, on the emergency department. So while the prevalence of elder mistreatment in the community is high, around 10%, only 0.1% of older adults in the emergency department are being diagnosed with elder mistreatment. So we focused here to start because we know that emergency departments disproportionately care for older adults with known risk factors for elder mistreatment. And there are aspects of the nature of care in the emergency department that lends itself to being able to identify it there or offers, unique opportunities for identification and response. For example, patients are in the emergency department for an extended period of time, and they're seen by multiple different types of providers during that time. There's typically an opportunity to ask older adults questions privately, as well as observe some of their interactions with care providers who may be accompanying them to the emergency department. So there was a number of reasons why we felt, let's start here. And as part of our work together on the National Collaboratory, we've also spoken to older adult survivors of elder mistreatment and asked them to respond to this question of, should we be screening in the emergency department? And I wanted to share this quote. When asked to share their perspective, one older adult survivor of mistreatment told us, "Getting trapped in this environment that you can't get out of, in a position of going to the emergency room for that kind of abuse, I can guarantee you the reason they're there, that's not the first time they were abused, it's the worst time they've been abused." And so I think this quote nicely illustrates the urgency for helping to prepare emergency departments, not only to identify the most obvious cases of elder mistreatment, but how to identify signs of abuse before it reaches that point. So on the National Collaboratory, we set out to design a model that could help emergency departments address elder mistreatment, including some of those more nuanced signs that may pop up earlier. And we wanted to design a model that would not overburden staff and had careful consideration for what matters to older adults themselves. So now in our third phase of this work, we aim to achieve 3 goals related to the dissemination of the toolkit. We want to reduce the number of missed opportunities to identify cases of elder mistreatment in the ED. We want to increase referrals to appropriate authorities and community-based services. We want to reduce repeat victimization and possibly reduce repeat hospital ED visits, unnecessary hospital ED visits. So I talked a lot about what we did to develop the model, but what is the model? I'm going to put one link in the chat, which is to our toolkit materials. So you can take time to look at these. These are publicly available tools. They're freely available to anybody that wants to use them. And I'll talk a little bit now about what the toolkit entails. So as I mentioned, with our focus on the emergency department, we engaged in an iterative design process where we worked in close collaboration with clinical and community partners to design what is now called the Elder Mistreatment Emergency Department Toolkit. This toolkit includes 4 core elements. The first element of the toolkit is an online survey that emergency department staff take. That survey assesses their perceptions of elder mistreatment practice, the available resources in their organization for addressing elder mistreatment, and what needed changes are there to better address elder mistreatment. Participating in that staff survey, the results of that staff survey then help to drive some of the systems changes necessary to implement the following 3 elements. The next element are online staff training modules. These are modules that are tailored to each staff's specific role in implementing the third core element, which is the screening and response tool. The screening and response tool is, of course, probably the crux of the model. This is what's happening day-to-day, patient to patient. And it's an algorithmic screening and response tool. It begins with a very brief pre-screen that includes a couple of questions about elder mistreatment and a guide on what to look for in terms of observational red flags, things that you might just observe in a patient, their caregiver, or the patient-caregiver interaction. that would indicate a need for more in-depth screening and potentially response. And then the final core element, which I think is probably the most relevant for many people on the call today, is a roadmap for leveraging community resources that can support patient-directed discharge planning and follow-up for older adults who may be experiencing elder mistreatment. A couple of notes about the model. One is that it is designed to be integrated into existing workflows with minimal disruption to current ED practice. That is, we want people to be able to implement the model without the need to hire any additional staff. It is important to note, while it wouldn't be a new hire, that we highly recommend that each site identifies a clinical champion that can oversee model implementation. This could be one or more people, typically a nurse or a social services provider, who are passionate about the topic of elder mistreatment and are willing to engage in a bit more training to become sort of the in-house experts in elder mistreatment and oversee the model implementation. Next, I wanted to share a diagram that shows just an example of how the screening protocol might be implemented. So by the time they're ready to implement the screening protocol with patients, the site has already engaged in the staff survey, staff have been trained up, and they've engaged with the community connections roadmap in a way that they know what to do next if they identify elder mistreatment. So they are ready to begin screening patients. The screening protocol at the time of the feasibility study included 2 brief screen questions. The new revised version includes 3, but there's 3 questions and a guide for observational red flags that may indicate concern. If there's no concern based on the brief screen, that patient just receives ED care as usual. If there's any concern based on the brief screen finding, the patient then receives the full screen protocol, which is a more in-depth screening with 6 questions about elder mistreatment. At that point, it can either be the same clinician that delivers the brief screen, moves right into the full screen, or they may hand it off to another provider, either somebody with somebody in social work or another nursing professional with specialized training. The point of the full screen is that it allows the provider to collect enough information that they are able to make a clinical judgment about whether they suspect elder mistreatment is happening, whether they feel the patient is at high risk and could use some additional services, or if they don't suspect a risk for elder mistreatment at all, in which case that patient would go back to ED care as usual. If there's a reason to believe that either the patient is experiencing or at risk for elder mistreatment, they then proceed to the response protocol, and that walks them through a process where the clinician documents their findings, develops a safety plan with the older adult, reports to Adult Protective Services in line with state requirements, and ensures that the older adult has a safe discharge plan, including referrals to relevant community-based resources. So that's kind of how the screening tool works in the clinical setting. And then I wanted to say a couple more things before we get into the feasibility study piece about the community connections roadmap. So during our formative research, we heard from clinical sites that they feel like the emergency department is a place where screening and referral can happen to a greater extent than it had typically, but it's what happens next that may determine whether an older adult is able to stay safe. And many providers felt discouraged from improving screening practices because they didn't know what would happen, or they didn't feel confident about what would happen at and following the time of discharge, since many emergency departments don't have the capacity to follow up with individual patients. We also knew from our literature review that multidisciplinary teams are among the most common and well-evaluated programs for addressing elder mistreatment. But again, many hospitals don't have the resources to stand up or develop an MDT right away. So the Community Connections Roadmap was designed to help hospitals establish relationships with the community resources that can support that more patient-directed discharge, and that they could feel confident that when the patient left the hospital, there was somebody in the community that could follow up, and that they would be safe after they leave the hospital. A little bit more about that. The roadmap itself begins by focusing on the relationship between the hospital and Adult Protective Services to improve coordination around reporting. In the next phase, once the hospital is ready, in the connect phase, they're encouraged to identify and prioritize connections with a few additional community resources that can help meet the specific needs of the specific population of patients that that hospital sees. And the types of organizations may be different for different hospitals in different areas. The toolkit does include guides for figuring out what types of resources might be relevant, what role they might play in helping to address elder mistreatment, and tracking tools for managing that outreach. And then finally, if and when the hospital is ready, they can move on to a more collaborative approach where the different organizations would come together to the same table. This could look, or this could be a multidisciplinary team, in which case we point people using the toolkit, the roadmap, to look at the Department of Justice's fantastic multidisciplinary team resources. Or it could be that the hospital identified that they have some existing teams that could be repurposed or leveraged to also include addressing elder mistreatment. So the goal is to start with APS and gradually move towards a more collaborative approach that includes a wider group of community organizations. Okay, so that's all kind of the background on the collaboratory and what the toolkit is. And now for the more researchy piece, I'm going to tell you about the phase 2 of our work, where we actually implemented and evaluated the Elder Mistreatment Emergency Department toolkit in a feasibility study. So the feasibility study questions were quite straightforward. We wanted to know, is the toolkit feasible to implement in the emergency department? Can EDs better identify and manage elder mistreatment when they use the toolkit? And how does implementation of the toolkit affect ED functioning? That is, by trying to introduce this toolkit to the emergency department, are we causing a lot of problems in how the ED is working? To answer these questions, this study utilized a small-scale mixed methods design. We collected and analyzed data from multiple sources. So that's what this busy slide is showing you, all the different sources of data that we collected. The main focus of these data collection activities was to determine the extent to which sites were able to achieve 7 feasibility criteria. That is practicality, acceptability, utility, implementation, integration, adaptability, and initial efficacy. Primary quantitative data came from institutional assessment, that is the EM-EDAP staff survey, which was administered with help from the clinical champions at each site. And that was administered to staff immediately prior to the toolkit being implemented and at the end of a 9-month implementation period. That assessment, there's a reference at the end, we've published on that assessment. It's modeled after the geriatric institutional assessment profile. Qualitative data collection included focus groups and semi-structured key informant interviews with emergency department staff, including the clinical champions at each site. Those happened at 6 months into implementation and immediately post-implementation. We also held regular TA check-ins, and we facilitated cross-site conference calls, and those all contributed to the qualitative data that we had to analyze. Other quantitative data included staff changes in knowledge before and after participating in our training modules. And we collected de-identified patient data, which allowed us to calculate screening rates at each site, and as well as aggregate hospital level data that included things like emergency department length of stay, 30-day ED readmissions, and hospital admissions. We used a convergent mixed methods approach. So we analyzed the quantitative and qualitative data separately, and then we integrated results at the interpretation and reporting stages. So the feasibility study included implementation at 5 hospitals across 5 states. Those were New York, Massachusetts, New Jersey, North Carolina, and Texas. The hospital sites that we selected varied in geography, type, and demographics. So these included both large urban hospitals, as well as academically affiliated hospitals and small community hospitals. We began implementation in February of 2020. So remarkably, the 5 hospitals that began implementation in February 2020 were actually able to continue screening for the entire 9-month period, despite the COVID-19 pandemic beginning in March. For me, that's one of the major findings of this study, is just that they could keep using it despite everything else going on at the beginning of COVID. But I will show you the real results now. So just a note that we first revealed these results at this year's 2022 Tamkin Symposium, which is a fabulous conference of researchers and practitioners hosted by USC. So if some of this looks familiar because you are at Tamkin, that's great. If you haven't gotten a chance to attend the conference, we do highly recommend it. But some of this will look familiar. It has been a bit updated since then. So related to the first question about whether the toolkit is feasible to implement, we learned that overall, staff felt that the toolkit aligned well with workflow and that the elements were easy to implement. For example, staff commented that while the elder mistreatment screening and response tool may look quite lengthy at first glance, it is really quick to implement. And once they used it, as long as they used it once, then they felt really comfortable with using it again and didn't feel overwhelmed by the tool itself. We did see variation in implementation across sites. So for example, at some sites, the tool was embedded into the medical record, we also saw variation in which staff members were responsible for using the different parts of the screening tool. So for example, the types of staff that were responsible for delivering the brief versus the full screen and the response protocol. And we also saw variation in whether and where in the process there was handoff between staff members. For example, at 2 sites, nursing staff were responsible for implementing the full EMSTART protocol. And at another site, nurses were only responsible for the brief screen and then would be able to hand off to either social worker or other specialized staff to complete the full screen and response protocols. The screening tool itself was also modified and tested. So for example, one site added additional observational red flags and a third question about financial mistreatment to the brief screen. And they tested that to see if that would screen more patients in to receive the full screen protocol. That particular adaptation was carried forward into the updated toolkit following the study. I'll say a bit more about that in a few minutes. In terms of participation rates, we saw a range in training rates from 58 to 93% of staff participating in the training at the beginning, and a range in screening rates from 18 to 87% of all older adult ED patients being screened for elder mistreatment. I will share more about the screening rates on the following slides, but I think one of the biggest accomplishments was also that over 15,000 older adults were screened for elder mistreatment during the 9-month implementation period. And that's a lot of people. So next question. Now related to question 2, can EDs better identify and manage elder mistreatment when they implement the toolkit? The training assessments indicated that there were significant improvements in staff knowledge about elder mistreatment identification and response. We also found that a greater proportion of emergency department staff felt prepared to recognize and intervene in cases of elder mistreatment. While screening rates varied by sites, they did increase over time at the sites. And what I think is the most compelling finding again is that they kept screening throughout COVID. Positive screen rates did range from 1% to 4% on the brief screen and from 0.04% to 1% on the triggered screen. Finally, we found that there were remaining gaps after implementation, and those gaps included things like understanding about how to work with APS, how to screen patients with cognitive impairments, and working with patients with psychological trauma. And this is a great example of where we saw needed changes to the elements, and I'll share more about that at the end when I talk about our next steps and revisions to the toolkit. Question 3, the third and final research question, was about whether implementing the toolkit caused disruptions to ED functioning. We found that the toolkit aligned well with existing workflows, but that some prior practices are pretty difficult to supplant. So sites with screening tools embedded in the medical record experienced fewer disruptions to workflow. And that's not surprising versus trying to introduce a paper tool into the workflow. Some sites were more affected by COVID-19 than others. And some sites had other competing priorities on top of COVID-19. For example, at one site, they were dealing with widespread power outages and flooding on top of COVID-19 surges. We did find, though, that through implementing the toolkit, emergency departments were able to build their connections with community resources. And we found that in at least one hospital, and the example we will provide later today, they reported that not only did engaging with the Community Connections Roadmap improve their relationships with organizations outside of the hospital, but also internally the communication between the emergency department staff and the social services staff. And that was really important to them as being one of the major improvements that they saw. I've mentioned it a couple of times, but I think it is important to really acknowledge the context of this feasibility study taking place during the start of the COVID-19 pandemic. And the study was deeply impacted by this, and EDs were and still are deeply impacted by this. So just a couple of notes about the ways we saw the COVID-19 impacting. ED resources were just completely overwhelmed at times, and it didn't just happen once in the beginning, but it kind of ebbed and flowed throughout the feasibility study. At many points in the study, resources had to be redeployed and there were changes in workflows. Amazingly, sites decided to keep screening. They felt that this was an important enough initiative that they wanted to keep using the screening tools despite everything else going on, including things like staff, leadership illnesses, and needing to be in quarantine, being understaffed. Importantly for this study, and the volume of older adult patients decreased dramatically, that there were just fewer older adults coming into the emergency department. And there were fewer times when older adults could be accompanied by a caregiver, which is actually a major piece of the screening, is being able to observe their interaction with the people that are accompanying them. There were reports that we were seeing more cases of self-neglect because patients couldn't get needed services. Oops, and that's the end of the slide. I did want to provide, though, one example of some of the changes in workflow. So at one site, the emergency department actually switched to doing their triaging at curbside. And that site decided to adapt the brief screen protocol so that they could also screen for mistreatment at curbside while the patient was in the car. So they tried that and used it for a little while. To me, that shows just how dedicated they were and saw the need for screening for elder mistreatment, that they were willing to take the screening outside with them when they were seeing patients at curbside. And then this slide is not an exhaustive list of the types of organizations that sites engaged with, but it does help to illustrate some of the kind of the range of community-based supports that hospitals worked with in implementing the Community Connections Roadmap piece of the toolkit. And I'd just like to say that always the connection with Adult Protective Services was important. And from my perspective, that connection to APS could really make or break staff's confidence in their ability to screen and respond to elder mistreatment. When they feel that they have a strong connection with Adult Protective Services and they know what they're supposed to do next, they're much more confident in using the screening tools. So kind of a summary, overall, we did find that it's possible to deploy this model in emergency departments, both large and small, and with varying levels of resources. The model is adaptable and it can be used to identify not just the most obvious cases of elder mistreatment, but also those more nuanced cases or those older adults that may be at high risk, but not currently experiencing elder mistreatment. Clinical champions and community-based organizations are really critical in implementing the model and play a large role in the success of the model. There's also the need to prioritize getting the screening protocol into the emergency medical record, electronic medical record, to facilitate workflow. And there were several areas that were identified to improve training, and a bit more on that a little bit later. Next, what I'd like to do is focus on one site in particular to illustrate how the tools could be implemented and how the relationship with Adult Protective Services was built. And then through that, I'll hand it over to Bree Cunningham, who will speak to the prospective Adult Protective Services in this work. Okay, so the Massachusetts test site, let me tell you a little bit more about them. Haywood Hospital is a small regional hospital located in north central Massachusetts. There is a social services department available to the emergency department, though not dedicated to the emergency department. And they do have inpatient geriatrics and psychiatry services. Let me share with you how specifically at Haywood Hospital the elder mistreatment screening and response protocol happened. So first, the electronic medical record flagged patients who were 60 and older. In this state, 60 and older is the older adult protective services criteria. So we went with 60 years and older who came into the ED. So patients were flagged by the electronic medical record. That led to bedside nurses then administering the brief screen to all flagged patients. They documented whether the brief screen raised concerns for mistreatment and whether further assessment was needed. If the brief screen was negative, meaning there was no suspicion of elder mistreatment, the patient would receive ED care as usual. If the brief screen were positive, indicating possible mistreatment, the same bedside nurse would continue on to use the more extensive full screen protocol. that they implemented using the paper screening form. So all the electronic medical record did really was flag the patient 60 plus. The full screen happened using a paper screening form. If the full screen was positive, signifying that there was a suspicion of elder mistreatment and or that the patient needed additional services, the nurse would document the findings and refer the case to social services department for further review and referral. It could be either the nurse or the social services staff that would submit a report as needed to Adult Protective Services. So that's kind of just to give you a flavor of how this was happening at Haywood Hospital. And then in terms of toolkit implementation overall, the purpose of this slide is to give an indication of Haywood's participation in implementing each of those 4 core elements. So for the first part, the staff survey, the Elder Mistreatment Emergency Department Assessment Profile, or EMEDAP, 66% of all staff completed that survey. The result of the survey indicated that Haywood staff felt they were effective in terms of recognizing and responding and even intervening in suspected cases of elder mistreatment, but they had several gaps in practices that were related to referral to specialized community services to older adults, reliance on family members for medical and social history information, and they felt that there was a lack of a streamlined response to elder mistreatment. In terms of the second core element, the training, Haywood staff had a really impressive 93% of staff completing the training. Part of the reason for the high participation rate here was that Haywood required staff to take it, and they compensated them for the time it took them to complete it. That was a decision that Haywood Hospital made. It wasn't a piece of the research team, and it didn't come from the grant for them to complete the training. Haywood stands out among the test sites also because of their excellent screening rates. The average screening rate for February through October 2020 was 84%. And I'll show on the next slide what those rates looked like month by month. In terms of the community connections, by the end of the implementation period, Haywood was identified as in the collaborate stage. So Haywood was able to leverage several pre-existing relationships with community partners, as well as with 2 long-standing community coalitions in its service area that had complementary goals. So there was nobody currently on a team to address elder mistreatment, a multidisciplinary team to address elder mistreatment, but by drawing on some related initiatives, they were able to pull together a more collaborative response. The clinical champions at Haywood did report to us that they found the roadmap to be very useful in helping them identify some of the critical stakeholders that they included in their efforts, like area agencies on aging, telehealth organizations, APS partners, and community physicians. Haywood started by reaching out to those stakeholders through community meetings and presentations to inform them about the ongoing elder mistreatment work that was happening at Haywood, and generate discussion among the stakeholders so they could create a closer working relationship with the stakeholders, including Adult Protective Services. On this slide, we see the number of 60 plus patients who came into the emergency department. Those numbers are in purple. The number who received the brief screen protocol in gold, and then the line at the top is the screening rate. As you can see here, rates started around 65%, but they quickly climbed up to 90% and then remained high throughout the implementation period. You can also see from this graph the decline in the patient numbers from March to April, and then a climb back up. Of course, that's very likely due to the COVID-19 pandemic. Over the 9-month implementation period, the emergency department at Haywood used the EMSTART to screen 4,588 or 84% of the older adult patients that came to their emergency department. Of those, 53 received the full screen, resulting in 24 referrals for additional services and 19 screened positive for possible mistreatment. Of those 19 patients, 11 were reported to APS, which is a more than 5-fold increase over their prior year. Most of the remaining positive screens were handled by Haywood's social services team, who connected the older adults to support in the community. And finally, before I hand it to Bree, I wanted to share a couple of quotes from emergency department staff about model implementation. The first staff said, "The elder mistreatment program helped us to really stress the importance of early identification, and nursing was able to buy in. The medical staff actually started to buy in too. They saw the fruit of their labors and the opportunities that were perhaps missed years back. We heard this time and time again that we know elder mistreatment is happening and we know that we're missing it, and we want the tools to be able to do something about it. Another person said, our relationships with Elder Protective Services was enhanced. We were able to affect change at a state level, a local level, and within our hospital system by working on this project. Elder Protective Services will work with me now. So they felt that was one of the biggest outcomes, as well as being able to improve their relationship and understanding about adult protective services. I'm going to hand it now to Bree for the Massachusetts EOEA perspective.
Great. Can you hear me, Kristen?
I can.
Perfect. Thank you. Again, my name is Bree Cunningham, and I'm the Director of Protective Services for the Executive Office of Elder Affairs, or EOEA. I'll probably say that a lot because Executive Office of Elder Affairs is very long. So a little bit of the background. For Massachusetts, I just wanted to paint a picture of how we function so that you could better understand why we did what we did. So in Mass, we are a bifurcated system. Our Disabled Protection Commission oversees those that are 18 to 59. And then we at Elder Affairs oversees individuals who are 60 years of age or older that live within the community. On top of that, we at Elder Affairs, we actually contract our, our protective service program out. We currently have 19 nonprofits, all of which are our area agencies on aging, and they're responsible, I'm losing my voice. They are responsible for the screening, investigation, and service planning of our protective service program. Because of the way we're structured, our engagement with the healthcare system, and specifically hospitals, is predominantly on the local level. So I at EOEA do not have a lot of engagement with the hospitals. Our local agencies provide the training to hospital staff, and some of them do attend grand rounds. However, all of this is done sporadically and does not always include every hospital within the Commonwealth. On top of this, with the consistent turnover of the hospital staff, as well as our local PS agency staff, that direct connection between the two of them is sporadic, and it's usually also left to the management level for staff. And it also usually stays on that training basis. It's more of get out to the hospital, train them on what PS does, go back, do your job. So our motivation for the National Collaborative was really to provide assistance in the creation of this tool, but really help bridge that gap between the hospital, us at the state level, and our local agencies. We wanted to help increase the understanding of elder mistreatment, but also really create a direct collaboration between our local PS workers and the hospital staff themselves. So our involvement with this toolkit process also was on 3 levels. It was on the state level with our secretariat, who was very interested in joining the collaborative and helping to bridge this gap. It was on my level where I provided information to Kristen and her team regarding what we thought could be made for improvements in regards to the hospital staff making reports, and also about how our agencies respond to those reports. I attended direct meetings with Haywood and really started to set that base level understanding of this was a collaboration, and we wanted to increase communication across all spectrums. Our local agencies provided the boots on the ground perspective to Kristen and her team. They met with Haywood staff. They attended and presented at grand rounds. They worked collaboratively with Haywood to create trainings and come up with ideas on ways to improve the process between the 2 sites. And really, they also created a connection that gave faces to names. This was huge. It wasn't just emailing somebody or calling somebody. You actually knew who was picking up or responding to that email, and it felt more personal. Next slide. So one of the biggest lessons learned, and Kristen and I have talked about this a lot, was very simple. Communication and system understanding between the hospital and PS is key. It actually encompassed everything. I'm sure for all of you who are on this webinar that do work within PS, the statement of PS doesn't do anything is heard a lot. And we really wanted to find out the root cause of this statement, to find out what was happening and why it was happening. And with our meetings, we were able to get at the heart of the statement for Haywood Hospital. We found that a lot of the issues for both sides really were based on a lack of communication and understanding of what each program can and cannot do. For example, one of the main concerns that the hospital had was the communication from PS after a report was made. And through just simple discussions, we found out that it wasn't that PS wasn't communicating, it was that the structure within Haywood created a barrier. Our regulations do require PS to notify a mandated reporter of how the report was screened and what occurred during the investigation. And we found that the individuals at Haywood who were receiving this information, were the mandated reporters, but the individuals who felt that they weren't getting the necessary information were not the reporters. So Haywood was able to create a process that bridged that gap internally and allowed for a flow of information within their own hospital. Another example was, Haywood was able to gain a better understanding of how PS within Massachusetts relies heavily on the services of the community, that PS may need extra time to find an older adult safe housing, not because they're taking their time to work through a case or they don't understand the hospital's urgency, but basically because that specific community that the older adult is going back to doesn't have housing. And they have to figure out a plan, and they may have to look in another area. That communication and understanding also aided in increasing the quality of the reports. The hospital staff heard directly from PS as to what they needed to make an appropriate screening, what they needed to really assess what the risk was, or to assess what the proper response time would be. Hospital staff started to really give more detailed reports to really hone in on what PS needed. It also created an understanding as to what could not be PS. So rather than Haywood sending in reports that then PS would screen out, it gave Haywood an understanding of what PS can and cannot do, and also gave them the direct connection to call and say, hey, I have this case. I know it's not you, but what do you think we can do about it? Lastly, it gave the hospital staff an understanding of our timeframes and why we need things as soon as possible. It gave them an understanding that if somebody is about to walk out that door, PS may not be able to get the services in place in time. So it really created more of a proactive response from both sides than a reactive response. And lastly, it gave both sides a real enhanced communication structure, a better understanding, which then allowed both sides to feel more support. Each side felt they were being heard. Each side understood where the other side was coming from, and they were able to form relationships that, again, someone could just pick up the phone call and call me or call the local agency and run something by them, as opposed to just filing and never hearing back. So these relationships, and Kristen, thank you for saying it, I added it to my notes. This became key during the pandemic. Haywood and PS worked very hand in hand throughout the entire pandemic, and even so now. And that one-on-one connection really set them apart from other agencies and hospitals during the pandemic itself. Thank you.
Thank you so much, Bree. Okay, so finally, we want to share a little bit about our next steps and then open it for question and answers. Okay. So what next? We are currently working to share the results of the feasibility study, including through presentations like this one and at academic conferences, and through a soon to be submitted academic paper. Following the feasibility study, the National Collaboratory did work hard to revise the toolkit based on the feedback we heard from the clinical sites and from older adults themselves about the screening protocol. Some of the modifications to the toolkit that we made included adding that third question to the brief screen related to financial exploitation. Personally, I was a little bit surprised that the emergency department felt that it was really important for them to be screening for financial exploitation. That seemed like kind of one that would be easy to write off as not medical and not needed. And they really felt strongly that we see it and we want to address it. So we added the question to the brief screen. We also adapted the trainings, which were previously for the feasibility study were voice over PowerPoint trainings. We developed those into interactive e-learning courses. We built the trainings out in addition to translating what was already there to address some of those gaps. So just as Bree was mentioning, we added training around APS, what is APS, what their role is not, and trying to help sites better understand how to make effective reports. We also included more information about techniques for asking the screening questions by drawing on some trauma-informed care approaches. Those are some examples. We are also working with partner sites to develop electronic medical record modules in the leading software systems, Cerner and Epic, that would be available to other sites that implement the model so that they would have the screening tool readily available in the electronic health record. And so the revised toolkit in its current form is available at the Geriatric Emergency Department collaborative site. The e-learning modules are now approved for CEUs and are going live literally any minute or any day. Those e-learning modules will be available. Everything that we've developed is freely available to anybody that wants to use it. And we encourage anybody that is interested in using the tools and would like more information directly from us to please contact us at ncaem@edc.org. You can also fill out an info form on the Geriatric Emergency Department collaborative website, which I think I finally got the link out to everybody in the chat. So that covers that. We had some discussion questions up here. I realize people can't unmute themselves, but if you want to chime in to any of these questions on chat, or if we want to move to some of the questions that have been raised in the Q&A, we could also do that. What do you think, Julie?
I think we can maybe read the questions. What barriers and facilitators to APS ED partnerships are you guys seeing in your work? The folks that are with us on Zoom, are you seeing any barriers to APS ED partnerships? And have you used any strategies to connect with hospitals and healthcare systems that have been successful that you want to share? And what other tools or resources would be helpful? I do actually have the ability to unmute somebody. So if you want to comment in the chat room that you'd like to share something, instead of typing it, you could speak it. I can unmute you, or you can just type your question in the chat box. We did get some questions in the Q&A box, Kristen and Bree. The first one was, when you get a chance, if not part of your presentation, did you look at patient acceptability and overall perceptions of the screening tool and experience?
So we did, and we are still analyzing some of those results. We took the latest version of the elder mistreatment screening response protocol and interviewed 20 older adult survivors of mistreatment who had been through the Adult Protective Services system. The official analyses are not complete yet, but what we're hearing from those are that yes, the tool is acceptable, that older adults feel it is important to screen in the emergency department, and they gave us a lot of helpful feedback about how screening should be done. Things like, don't just go through a checklist with me, start a conversation with me. You know, things that seem like they'd be obvious, but they're not always obvious. And they're especially not obvious when you're in the middle of a busy emergency department setting. So things that we have been able to incorporate into the training about how to approach the screening process. Otherwise, what we're hearing from those interviews so far, like, yes, the questions make sense to me. Yes, I think they should be answered, but they should be delivered a certain way. Which I think is really helpful and powerful. What we're doing next actually is we have a few of those older adults who have agreed to participate in videos so that they can tell their own stories by video, and we can share those as part of our training materials so that well, anybody, but especially emergency department staff can hear it from the older adults themselves, how they would like to be treated when they're going into the screening process. Okay, so I answered that one.
I'm sorry, Catherine Bingle said, relatedly, did you look at potential risks as well as benefits to patients?
So we did not this was just a feasibility study. So what we looked at is, can it be implemented? There is a need for more research, and the U.S. Preventative Services Task Force is looking for this research right now so that they can make recommendations around elder mistreatment screening. So it's a really, really important next step that was not part of this study.
Thank you. And then Ellen, and Ellen, I apologize if I say her last name wrong, Kolodny, says, has this toolkit and recommended protocols been utilized by a large municipal hospital? If yes, how successfully?
So I believe that our Texas site was a large municipal hospital. What we are doing right now also is in the process of posting case studies about each of our participating sites that go into detail about what they did and how they did it. So if you go to the Geriatric Emergency Department Collaborative website in the next week or so, those will be up. All of this stuff is coming out at once. But yes, they were a site that implemented it. They are the site that is currently working very hard to get it into their electronic medical record. And they are going to continue implementing it following the feasibility study. So successfully enough that they want to keep using it. And there are many more lessons to be learned from them specifically that will be posted in the case study in the coming week or so.
Wonderful. And then our good friend Carol Dayton, co-chair of the NAPSA's Research to Practice Interest Group, says, how will you account for variations in state laws when you do the national distribution? Example differences, whether age only definitions for APS or age plus incapacity, vulnerability.
It's such an important question. It's one that we've considered a lot as we developed not only the training for this specific model, but we also developed a training for EMS providers for that to be distributed nationally. And what we've ended up doing in the trainings is providing criteria on what reporters need to be aware of in terms of how the state laws vary, and pointing them to look at their state laws and providing job age that would be easy to fill out for them. So you need to go to understand what the age is. What are the other criteria? If you have patients that are coming to your hospital from nearby states, the criteria are probably different. So we train them how they vary and what they need to look for in their own states. But we are not able in the training to say, like, if you're from California, this is what your rules are. If you're from Texas, this is what your rules are. So we point them back out to the other resources that do provide the state level information.
A couple more questions. How available is the ED staff to subpoena responses, both criminal and civil probate?
I don't think that we had any cases where ED staff were subpoenaed, so I don't have an answer to that question.
Okay. And Angela Rosado said, were there any findings for those patients who screened positive for elder mistreatment or self-neglect and linked to APS that demonstrated slow down or prevent rehospitalization or recurrence of abuse?
It's a great question, and that is for future research. Again, ours was just a feasibility study. We did not have patient level data on hospitalization and things. We did have aggregate data, hospital level data, but they're really difficult to interpret given that the implementation period was COVID-19. It's just really hard to say if there's changes that were this toolkit or the fact that it was a pandemic. But excellent question.
And then Jean says, how will you expand the program and recruit new hospitals?
Excellent question. We are in the process of doing that now. We are partnering with the Geriatric Emergency Department Collaborative and Accreditation. So that's why our toolkit is hosted on that site. One of the motivators for some sites will be that implementing the elder mistreatment emergency department toolkit can help you work towards accreditation as an emergency department, geriatric emergency department. So that's one way. We also have had a lot of interest from the sites that participate in the feasibility study. Many of them have kind of sister hospitals or other hospitals in their networks that are now interested in participating. And so kind of word of mouth. And then the other way is doing things like this. So if you all on the line have relationships with hospitals that you think this would be a good fit for, please point them to our materials and give them our contact information. We are at this point able to provide individual TA to sites that come on. So now's a good time to kind of get in and get some direct help from the experts on the National Collaboratory.
Wonderful. Well, the last two questions are really about where they can access information, the study and the actual training materials. And I think you put a link in the chat box. I tried to copy and paste it, didn't work. Use Kristen's link. Kristen's link works. I want to just, before we conclude, give a few final announcements. It's right at 3 o'clock. So if you like today's presentation and you want to ensure NAPSA can continue offering webinars, trainings, advocacy, and more, please visit www.napsa-now.org to make a donation to NAPSA. Donations of all sizes are greatly appreciated. We also encourage everyone on this call to become a NAPSA member, which can also be initiated at napsa-now.org. Thank you to NAPSA's Research to Practice Interest Group, led by Dr. Marion Liu and Carol Dayton, for organizing today's webinar. And an extra special thank you to Dr. Kristen Lees-Haggerty and Bree Cunningham for presenting today. We really appreciate all the information that you shared. Thank you so much. And thank you to everyone who listened in. A recording will be available on the napsa-now.org website within the next 48 hours. And thank you for attending. Bye.
Thank you so much.